Hi guys, this video is about presbyopia. So presbyopia is aging eye. So how is it different? It is not a refractive error but physiological accommodation insufficiency associated with aging. So we studied myopia, hypermetropia, astigmatism. All these were refractive error, but this is not a refractive error. This is a physiological insufficiency in the accommodation. So there is an accommodation insufficiency due to aging. And here we can see progressive near vision fall due to irreversible accommodative power decline of the crystalline lens. So due to aging, what happens is our crystalline lens accommodative power will decrease. And due to that, there will be progressive near vision fall. That is, cannot read a book, cannot read a newspaper. He will have progressive near vision fall, and that is due to what? Irreversible accommodative power decline of the crystalline lens. Coming to the pathophysiology, here what happens is the near point recedes beyond the normal range. So for a normal person, the normal range of reading is 25 to 30 centimeter. So if it go beyond 30 to 35 centimeter, that is the near point recedes beyond the normal range, and this will be a progressive receding with the age. So that is the pathophysiology. The near point recedes beyond the normal reading range. Now coming to the key mechanism, actually three things are happening. With the age, there will be nuclear sclerosis, capsular changes, and also ciliary muscle power losing. So nuclear sclerosis means what is happening is the lens is getting hardened. The lens substance, the nucleus in the lens will be getting hardened. So what happens is the lens will lose its elasticity. Also due to the capsule, the lens capsule will lose its elasticity. So due to the capsule, due to the nucleus getting hardened, there will be less moldable lens. And also due to the ciliary muscle, the muscle power of the ciliary muscles will decrease, and that will also contribute to presbyopia. So what happens is the person's near point will recede and he will have a progressive near vision fall. And this is due to aging. Other than aging, there are some other causes of premature presbyopia, that is presbyopia before 40 years. That can be due to uncorrected hypermetropia, where the accommodative reserve is already used for distance vision and now there is no accommodation for near vision. So it can be due to accommodative hypermetropia, premature sclerosis of crystalline lens, or presenile ciliary weakness. So before the senile itself, the lens is becoming sclerosed and also there is ciliary muscle weakness, or it can be due to chronic simple glaucoma, that like primary open angle glaucoma. So these are the causes of premature presbyopia: uncorrected hypermetropia, premature sclerosis of crystalline lens, chronic simple glaucoma, and presenile ciliary weakness. Now what are the symptoms? So coming to the symptoms, there will be difficulty reading small print, that is the newspaper print, telephone directory, the person cannot read. And one more thing is there, that is the person will hold the material further. We can see our grandparents holding the books and other materials further to read better. So that is known as trombone effect. So what is trombone effect? In the persons with presbyopia, to read clearly, the people will hold the material farther, mainly in reading the small print. That is known as trombone effect. Then there can be asthenopia, that is eye strain, headache, tired eyes. Why? Due to excess ciliary muscle effort to accommodate. And also there will be difficulty in reading in the dim light, and there will be intermittent diplopia due to accommodative convergence relationship, and that is rare. So the main thing is trombone effect, asthenopia, and difficulty in dim light. Now coming to the signs, we can see that the near point will be recede. So there will be receding of the near point of accommodation, and when we give them near vision chart, the near vision acuity will be less than N6. Okay, that are the signs. Coming to the treatment, optical management is there, surgical management is there. Optical management, we are giving glasses. But here what is important is, first we have to correct the distant vision. Distant error should be corrected first, then we have to give the presbyopic add. Okay, first distant error has to be corrected, then presbyopic add. So we are giving a convex plus lens for the correcting the presbyopia, and weakest lens principle has to be used because we have to keep the accommodation active. So we have to give minimum power lenses. So convex plus lenses are given for presbyopic add. And what is the add that we are doing is, in 45 years we will do +1 to +1.25. If it is 50 years, we will do 1 + 1.5 to 1.75, and in 55 years we will do up to 2 to 2.25, and then after 60 years it is actually up to 3 diopter addition can be done. And this lens can be bifocal lenses, that is both concave and convex is present. So we can see a glass where here under one lens and over other lens. Then trifocals can be given, and progressive addition lenses can also be given. Coming to the surgical management, it can be by corneal surgery or lens-based surgery. Corneal surgery include monovision LASIK. What is monovision LASIK? Here in one eye we will do distant vision correction and in other eye we will do near vision correction. Or it can be by presbyopic LASIK where we will do multifocal ablation, or CK. What is CK? Conductive keratoplasty that we done for hypermetropia can also be done. Then lens-based surgeries include refractory lens exchange that we do in every refractive surgeries. We can also we can do refractive lens exchange, or multifocal IOLs or accommodating IOLs can be given. Okay, so this was all about presbyopia. It is aging eye and this is not a refractory error. It is actually what? Physiological accommodation insufficiency. So I think this was useful for you. Thank you.